Transitional care. Here are the objectives. Throughout the lecture, I'm going to try to call out areas that you need to focus on and study. If you can't stand the drone of my voice, there's a study guide that is going to accompany this lecture that'll tip you off to key things to look at. So what are we talking about with transitional care? Coordination from point A to point B in a patient's journey through the healthcare system. So it's a very, very important topic now more than ever, because healthcare is moving out of the acute care setting, out of the hospitals, into patients' homes, into skilled nursing facilities, rehab facilities, outpatient care clinics. Why? Because it's really expensive to keep people in the hospital. So if you don't know what Medicare is, I suggest you get at least a quick overview. This YouTube's about 3 minutes long. It's really important to understand that Medicare is how most of our patients get their care paid for. It takes care of people who are 65 or older in this country, and it is full of lots of little ifs, thens, and buts about how reimbursement occurs. Do you need to know all of those? No, but the more you work in the field, the more you need to be aware of certain kind of hard stops and gotchas. Okay, anyway, hospitalization is just one part of the healthcare continuum. That's kind of what you're getting most exposure to in your nursing program, but it doesn't mean that's where you're going to end up working as a registered nurse. There are about 10 million, more than 10 million discharges from American hospitals every year. Patients are staying in hospitals, acute care hospitals, for a shorter duration, and they're sicker when they're discharged than ever before. The Joint Commission has specific guidelines for discharging patients, and Medicare will not reimburse if these guidelines aren't followed or similar guidelines aren't followed. As well, if a patient bounces back within 72 hours for the same issue, the hospital will not be reimbursed. So one really hot issue right now with acute care transition is something called observation status. There's some states have legislation pending about this, but it's becoming more and more common practice to hold patients in what's called observation status. Usually this is in emergency departments where they're not officially admitted to the hospital. These are patients who previously, in prior decades, probably would have been admitted to the hospital. They're usually very sick, but we watch them for up to 24 hours to see if they're going to kind of declare themselves as needing acute care intervention. So please take a look at this YouTube video. It's another 2 or 3 minute segment on what is meant by observation status. There's also a New York Times article posted for you. This might be a test question. So after the hospital, the acute care facility, there are a number of care options for patients who still need care. Post-acute care, people might go to a skilled nursing facility. They might go to a rehab facility. They might go home for home care or home for hospice or to another kind of facility for hospice care. So throughout this lecture, we're going to quickly touch on these different kinds of care options. So this list is a list of predictors of people who are going to have poor discharge outcomes, by which we mean they're likely to come back to the hospital. And as you can see from this list, it's pretty much all of our patients. The majority of our patients have one or more of these criteria. So one model that's been developed to try to prevent hospital readmission and to improve patient care along the care continuum is called the Transitional Care Model. It's been developed by nurses at the University of Pennsylvania, and it has advanced practice nurses, nurse practitioners, and CNAs doing intensive home follow-up, case management, and so forth to assure continuity of care, and it's meant fewer multiple readmissions and fewer hospital days in the hospital. So this graphic illustrates the various points of the transitional care model. And here's a different version of the same thing. And these are the different points in the transitional care model. I think the takeaway here is that kind of trying to provide patients with continuity of care, with wraparound services, and with some case management are keys to preventing readmission. So handoff and handover from care point A to care point B are the most treacherous point in the patient's care journey. So this is really where patients are significantly at risk. This is when we see a lot of codes. This is when we see a lot of slip and fall accidents. This is when we see medications getting missed. So it is your professional responsibility as a nurse to understand that the patient understands what's going to happen to them next, and that the people receiving the patient understand how the patient's going to be cared for. So all hospitals have people called patient care coordinators or case managers who fulfill this role in a formal professional way. But you as a nurse, as a staff nurse, are an integral part of this transition. So here we have a list of barriers to successful transition of care. It somewhat overlaps with that other list of people who are likely to come back to the hospital, but poor communication is always at the root of these bad transitions, incomplete transfer of information, language, health literacy, cultural differences, inadequate education. All right, so there are four pillars of good care transition. Assistance with medication self-management. The patient or their caregiver needs to know what the medications are, if there are any medication changes. We're encouraging patients to use their patient health record. A lot of people who belong to HMOs now have electronic access to their health record. They need to know if they're going to have any follow-up visits with specialists, and they need to know what that schedule is and so forth. And then they need to be able to verbalize or to show understanding of the red flags for their condition. If you're discharging a patient with CHF, it's a good idea for them to do some teach back to you. You know, what are the signs and symptoms of CHF exacerbation, weight gain, edema, dyspnea, that kind of thing. Anyway, this is common sense, but all these things often fall through the cracks. So discharge planning in a formal sense is a process fulfilled by a professional, usually a nurse, sometimes a social worker, to see that a patient is successfully transitioned from care point A to care point B. A physician has to determine that a patient is stable enough to be discharged from the hospital or transitioned from one facility to another. As a patient, you can appeal the decision for transfer, and patients often do. The discharge planning process begins upon admission to the hospital. Patient care coordinators or discharge planners are involved from admission, determining things like how many steps are in your home, so they'll know if the patient can actually get into the house. They're trying to find out if the patient's going to need a hospital bed. They're trying to find out who's at home to care for the patient. They're trying to figure out what the patient's financial resources are and what kind of care that can be provided for them. So high-risk patients, this is very similar to our list of people who are going to get readmitted, isn't it? But all of these people require careful discharge planning. Everybody requires discharge planning, but these are the people that you need to focus on. What can I say? This is almost all of our patients, right? Really key is people who don't have support services at home. So the discharge planning process involves all of these things and more. Figuring out what the patient's medications are going to be, what kind of support system they're going to have, what kind of educational needs, what kind of hard equipment they're going to need, hospital beds, walkers, toilets, etc. And here's more about discharge planning. And what can I say about that? It really is a specialty of nursing at this point, case management and discharge planning. And it can be an interesting one, but it requires a certain amount of tact and a lot of knowledge about Medicare laws and health insurance reimbursement. So the hospital has to provide a patient with a detailed written discharge plan, and also needs to convey that to the patient. Yeah, this is an interesting website if you have a chance to look at that. But so your role in the discharge, we're assuming here that you may be at some point working in an acute care facility. So your role is to identify any barriers to discharge. It is not unusual when you go to discharge a patient that you realize they're really not ready for discharge for a variety of reasons. It may be that you find out their home environment isn't safe for some reason that wasn't discovered earlier, or there really is no one at home to receive the patient and they're a fragile patient, or you have noticed some acute changes in their physical condition. All of a sudden they're short of breath and they weren't before, or there's some flash pulmonary edema, or their blood sugar has just dropped precipitously, or any number of things. And so please, 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 you need to wave the red flag and not discharge that patient. That's your professional duty. And I would say that happens 2 or 3 times a week where I work, that it's like, hold the show here. This person is not ready to go home. So obviously it's your job to communicate the patient's care plan if you're discharging them. You need to make sure that there's a way for them to get their medications. They need to know what their medications are, etc. Okay. So who discharges a patient? The physician authorizes the official discharge. The physician writes an order saying this patient's ready to be discharged from the hospital. But as a nurse, as I just said, you're involved in the actual physical discharge and the patient education part of it. The discharge planner, case manager, is involved in a heavy way in getting the actual plan in place. So out of hospital care, patients are referred to home health, skilled nursing facilities, rehab services. So the things that are reimbursed by Medicare require a physician order. A patient can't just say, I want to go to rehab, I guess, unless they're willing to pay for it out of their own pocket. But anyway, out of hospital care involves a referral process, all right? And this slide is, I'm sure, already inaccurate. It's a couple years old, but it's here to remind you that these services are all very expensive. Basic nursing home care, skilled nursing facility care is about $80,000 a year, and I would say it's probably a lot higher than that in the Bay Area. And these rates just keep going up and up and up. And so Medicare reimburses only for the first 20 days. And so after 100 days, an individual is responsible for all costs of skilled nursing. So this is something you should look at for the test, and that's the difference between rehab and subacute care and then skilled nursing facilities. So the takeaway here is that rehab has specialized care for people who are being rehabilitated to back to their baseline or to near their baseline, or that they can have improved functionality. So somebody with a chronic condition is likely not to qualify for rehab services because they've had the condition for a long time and they really wouldn't benefit from, say, physical therapy or whatever. But somebody who just fell out of bed, broke their hip, has had it repaired, and now needs rehab or physical therapy to get back to some kind of ability to walk would qualify for rehab. All right. And then the subacute, I'll go back to that. I don't know if you remember in that lecture on grieving and death, there was the man who had his wife in a subacute facility where a lot of the patients were on ventilators for long term. They weren't going to get any better, but they need specialized monitoring equipment and nursing care that was really more than skilled nursing. It's specialized, so it's called subacute. And there's long-term acute also. And I will not go over the distinctions between those two. But skilled nursing facilities provide skilled nursing care, 24-hour nursing supervision. Medicare usually only pays for a small amount of that, but these people are getting antibiotics or they're getting wound care. They're getting skilled nursing work like you learned in the skills lab, okay? Versus a residential care situation where people are getting assistance with their activities of daily living, okay? So rehab. So you should learn when people need rehab and when they don't, or when it's going to get reimbursed, rather. So it's usually long term. It's more than a couple days. And Medicare payment really influences this length of stay. There's two basic requirements. They must be able to maintain, that's requirement one, or they're trying to improve their functionality. So that's up to the physician really to determine whether or not the person's going to qualify. And there's often, you don't need to know, a lot of arguing about this, but that's rehab. Home health care is another transitional outcome for patients. People can get skilled care in their home. It can also be for people who are terminally ill, and usually that's called hospice care. And it can be used to avoid hospitalization for people who have chronic conditions. Again, typically not reimbursed completely by Medicare, and reimbursed really for people who have low income. There's income need testing. So education is also part of home health care. And here's a quick little comparison of the advantages and disadvantages. This is more kind of from a nursing viewpoint. You have a lot more autonomy as a home health care nurse. I have some friends who do it. They love it. But on the flip side, you don't have anyone that has your back, so to speak. So there are some personal safety issues, as well as just that lack of collaboration sometimes, like, hey, what do I do about this? Or I need help holding this person's leg, or that kind of thing. So I do worry too about with the increased number of home health care nurses, they're often being employed by small agencies. They may not be getting the same compensation, the same benefits packages, all this kind of thing that the larger hospitals are providing our nurses. So anyway, just something to think about. The role of the home health care nurse. In some form, you will be tested on this. So you're providing direct care, skilled care that a registered nurse performs. You're educating the family and the patient. You're an advocate. So you're supporting their rights to make decisions, right? If the patient says, I don't really want my family involved in my care, then you would want to support that. And you may be helping them connect to other resources, other health resources. So just know that there are a lot of reimbursement issues about home care, just like there are about all these other phases of health care. A lot of people end up using supplemental private insurance for home health care. Medicare will reimburse a certain percentage for a certain number of visits with very specific criteria. Home health care agencies, there are different kinds. A lot of nurses are opening home health care agencies, nurse run or physician run. These would be called proprietary. Some voluntary agencies run home health care agencies. Voluntary groups, rather, like a church group would be an example. Public would be the County of Alameda, the County of Contra Costa County have some healthcare services that they run. And then, of course, there's some hospital-based home health care. Kaiser, for example, has home health care nurses. I think John Muir does. Anyway, different kinds of service agencies. So this is the kind of question you might be asked on the test in some flavor. The nurse knows that the family of a patient receiving home health care needs further education about the service, when the family requests the RN to do what? Teach the patient about insulin, change the PICC line, take the patient shopping to buy high-protein foods, or call the social worker to obtain information about Medicare. So from that previous slide with the 4 things that the nurse can do, you know that the correct answer is C. The registered nurse is not going to take the patient grocery shopping, even if it's for high-protein food. You could determine if there's an agency that can help with that. You can help connect them with a home health aide, that kind of thing, but that is not your job to take them shopping. Okay, so another case study here. This one is also involving what kind of things would be under the purview of a registered nurse in home health care. So the IV antibiotics, yes. The ostomy care and education, yes. PT and occupational therapy would be a different professional coming into the home to do those things. Assistance with bathing, cooking, shopping, etc. That would probably be a home health aide. I could see maybe a nurse doing some patient bathing, but that really is not what the home health nurse is doing or reimbursed for. So Medicare only reimburses people who are homebound. The definition of homebound means that it takes a great effort for them to get out of the house. So that person, we didn't read the thing out loud, but that person had a lot of mobility issues. They would qualify for home care, so yeah, anyway, I guess if you're homebound, you still may be rare, on some occasions coming to doctor's appointments, clinic appointments, or maybe going to church occasionally, but basically you're homebound. You need short-term care. And so some of the things that a nurse would do would be diabetes management, medications, assisting with tube feedings, but usually we teach the family to do that, wound care, self-injections, teaching the patient to do self-injections. So here's something about skilled nursing facilities versus rehab. I want you to try to get a handle on what the difference is between those. This is a person who has some chronic diseases, but they've become deconditioned and are motivated to learn how to walk again. So the key here is motivated to gain ability to walk, and if the physician thinks that he would benefit from rehab, then the person may be able to qualify for rehab. Okay, so here is another set of bullet points that tries to differentiate between skilled nursing and rehab. I think we should cross this out. Actually, it kind of confuses the issue. Usually people in skilled nursing are not getting physical therapy, occupational therapy, or any kind of speech language therapy. So that's usually, we're hopeful that they're going to be improved and that they're doing this kind of stuff in acute rehab. Okay. So anyway, SNF admission criteria, they're on a trach or ventilator. They have, they need to have 3 of the following of these. Okay. So they need really skilled nursing. All right. And then in the acute rehab, some of you were in an acute rehab facility at Valley Care last quarter with me. Those people have to be able to stand 3 hours a day of therapy, which is pretty rigorous, really. They need close medical supervision still, and they have clear goals for rehabilitation, okay? And they have a clear post-rehab discharge plan. So the person who's had a hip replacement might still need close medical supervision. They can tolerate the physical therapy, and it's really realistic that they can get back to being able to walk and use that hip, okay? Admission criteria for the skilled nursing facility versus just a care facility. I know it's getting boring, but let's focus on it here. The skilled nursing facility is they're going to get antibiotic therapy, diabetic teaching. They may have pressure ulcers that are stage 3 or 4. In other words, that need a nurse to do the dressing changes. Anyways, they need skilled nursing, like the stuff we learned in skills lab. In a non-skilled, just a care facility, People can receive medications, but they aren't getting medication changes, and they're not medications that require skilled nursing intervention. So they might have simple dressing changes for just a stage 1 or stage 2. I would even question this IM thing. I think that people get insulin injections in non-skilled, but I would be kind of leery of the intramuscular injection thing. Anyway, that's the difference between the non-skilled and the skilled nursing facility or facilities. Okay. So here's another scenario. I'm not going to go over this one because we talked about hospice care previously, but you know about the hospice philosophy already. And just so anyways, this is just a reiteration of that. The final slides are about the nursing process.